What are the benefits you think the group model has delivered for the people of Liverpool and the staff of the Trust?
The structural governance risk model definitely delivered huge improvements. The organisation is light years from where it was in terms of performance, safety, inspection regimes, all of those things that have been looked at. It's a significantly safer place and it's a significantly better operating place.
Today's guest is James Sumner, Group Chief Executive Officer of the NHS University Hospitals of Liverpool Group, leading 3 prominent NHS Foundation trusts. His work focuses on strengthening organisational leadership, driving effective people management, and ensuring strong corporate governance to support better decision-making and improve healthcare delivery across the group.
When I first arrived in Liverpool, for example, the A&E departments had legal notices on them from safety concerns. They'd been rated inadequate by the CQC. The blueprint model for NHS at the time was almost, you'll have these committees and these will be the agendas and these are the things we'll discuss. And you sort of think, well, where's the room for things that aren't big on that agenda at that level? And it was a very big organisation. And from my perspective, I didn't think that traditional sort of pyramid structure at the top to bottom would work. So we moved to a sort of group devolved model. Very quickly, we went from inadequate and unsafe to rated good for safety and good for well-led and all of those things. I really like to work on a risk-based model. We absolutely, from the top to the bottom of the organisation, want everyone to use a risk-based reporting model.
Yeah, and I know it's a critical ingredient in your approach to performance improvement. When you're approaching the need for performance improvement turnaround, what are the kind of elements and how do you take them forward? And perhaps you could say a bit more about that risk approach.
From a turnaround perspective, the risk approach is definitely key. And what we try and do is
So welcome to the latest episode of the Delivery by Design podcast. I'm really pleased that we're joined this afternoon by James Sumner, who's the Chief Executive of the University Hospitals of Liverpool Group and has had a long and successful career in NHS management. It's great that you can join us this afternoon, James.
Thanks, Alastair. Pleasure to be with you.
That's great. I'd just like to kick off with a question I ask all our guests, which is really, when we talk about an operating model, what does that mean to you?
Well, I guess this is one of those trick questions, isn't it? I'll leave something out here along the way, but I think for me, how I view it anyway is much more than just the sort of wiring diagram. For me, it's that, firstly, the governance. What's the governance of the organisation? If you think about NHS organisations in particular, what is the governance and assurance model we're going to use for this information to flow? There's definitely something about the leadership development in that model and our consistent application of leadership, because one of the hardest things is trying to get everybody to sort of act and behave in the same way. The third part for me, but this may be quite a specific thing to me, is I really like to work on a risk-based model. So within the governance work, we absolutely, from the top to the bottom of the organisation, want everyone to use a risk-based reporting model. And then the final bit is the sort of rules of engagement. How do we work together? How are decisions made? Because that's probably one of the most tricky things to get right in large hospital groups is decision-making authority and how you work around that.
No, that's brilliant. I was going to ask you, if you compared that group model to a single hospital, is that the biggest difference? I mean, do you want to say a bit about that difference? Because you've clearly led and scaled through from individual organisations to a group level.
Yeah, no, that is the biggest difference. I think in a single organisational model, it's the governance is pretty traditional and usual within an NHS trust, which is fine. The biggest complexities, I think, are trying to devolve leadership in a sort of strict NHS foundation trust model where accountability sits with certain individuals around the board table, for example. So trying to make sure you can devolve as much as possible, and making sure that decision-making and delivery is taken at a local level, but in a way that keeps a level of consistency of approach is always a tricky bit as well. So they're the two things really, I think, that are the hardest to actually manage.
How have you found taking your non-executive colleagues and your boards on this kind of journey of, are there particular aspects of the development where you have to work with board colleagues?
Yeah, I mean, when I first arrived in Liverpool, for example, I should state at the beginning, we actually put the sort of group governance model into what is a single organisation, although it is at the time, but it had just merged. And it was a very big organisation. And from my perspective, I didn't think that that traditional sort of pyramid structure at top to bottom would work. So we moved to a sort of group devolved model within just that organisation. And I probably spent, I think, 4 or 5 weeks, sort of every week with the board, in particular Ned's chair, others, just going through how we'll still get our assurance, or indeed how assurance will be greater in this model than in the one where, for example, Ned's chair all the committees and the usual way that we've been used to working. So we sort of did a lot of work. So from my perspective, I funnily enough looked at this the other day for something else. I had a sort of 30, 40 slide presentation that we continued to take the board through and iterate, that described everything from the sort of governance model to the agendas of the committee meetings and what would come there and who would present what and what the rules were around decision-making authorities, the SFIs, etc. So there's a lot of going through that to make sure everyone was cited. And then sort of after implementation, the test then was almost, well, does it feel any different? And I remember one of the non-executives saying, I won't mention which bit of the organisation, but he sort of said, look, I've been here 2 years and I didn't know that bit existed until you started doing this from a very much risk-based approach. And suddenly we've uncovered a lot of risks within a part of the organisation I don't think we were cited on. So those sorts of things obviously help embed it.
Yeah. So that sounds fascinating. Having spent 13 and a half years as a non-exec director and having been through the kind of merger of trusts and then a development of trust and then the move to a foundation trust and all the associated kind of changes in governance, I think that risk-based approach is really attractive because, as you said, the risks you're carrying often on in the main areas you've all got your eyes on, it can come and bite you from behind in areas you're not so aware of that are maybe out of the usual glare of attention.
I mean, that's the thing for me, is almost the blueprint model for NHS trusts at the time was almost, you'll have these committees and these will be the agendas and these are the things we'll discuss. And you sort of think, well, where's the room for things that aren't big on that agenda at that level? And especially in a large organisation, how do you make sure those things that might be a smaller part of the organisation that, you can't possibly know every corner of it. So how do you do that? And the only way, in my view, to really get to that is to really embed a different method of approaching and scoring risk within an organisation. And it's really difficult. I've done it in a couple of organisations, so 4 now, and very difficult to do. Or I won't say difficult, but maybe quite resource intensive to do. But once you get it right and people start and things settle down with that system, you will find out all sorts of things about your organisation that you never would have. And you need to be prepared for that. Our risk register suddenly grew, and then it shrunk. And then that test of, when we look back after the first year, are we still holding the same risks with a different score, or have we managed? And it's really pleasing to see actually risks coming up, getting managed, going down again. And it's a really good way of doing things, I think.
Yeah, and I know it's a critical ingredient in your approach to performance improvement. So
Yeah.
do you just say a bit more about, when you're approaching the need for performance improvement, turnaround, whatever it's called in an organization, what are the kind of elements and how do you kind of take them forward? And perhaps you could say a bit more about that risk approach, because it sounds key to me.
I think the risk approach is definitely key. If I perhaps start there, which is so for example, across our group, since the day we started to now, we have an assurance risk committee, which is effectively the main committee of the board. And that's where each of the hospital sites and the leadership team, exec managing director, comes. And they present all of their highest scoring risks over a certain threshold and tell us what the mitigations and controls are around them. And obviously, if there's anything there they can't deal with without board support, we would deal with that there. Those risks are all linked to performance data that shows in their IPRs, their performance reporting systems. So we can sort of see this risk is associated with this metric. And we use statistical process control, so we can see whether there's a genuine improvement or deterioration in a metric to tell us if that's having an impact on that risk. So, and then we have their sort of written report of what they've been doing in their board meeting to focus on those risks. So what NEDs would get, and I get, is that view of, I can see this particular hospital's been discussing these key risks that are high up on its risk register. I can see the conversation they had in their meeting, and I can see the metrics that tell me whether, if they're telling me there's an improvement, I can see it. Or if they're telling me there's not an improvement, but they expect to see one, I'll be able to see it when it happens. And when combined with then that whole principle of visibility from the board, of getting out and walking around the organisation and speaking to staff, that's a good test. And certainly when we've had well-led inspections with the CQC, they were very impressed at the level that people could describe risks deep into the organisation that they felt were part of their hospital, because it was very well understood. But also the correlation between those risks being managed through those assurance risk committees and those hospital leadership boards. So that's sort of how we do it. If you think about the sort of performance side of things, we have a slightly different approach to that, which again came out of turnaround of what was at the time Liverpool Hospital. So we had really quite significant challenges when I arrived there with, well, everything pretty much. The A&E departments had legal notices on them from safety concerns. They'd been rated inadequate by the CQC in both cases. Lots of issues around deterioration of patients that went unnoticed and so on. Poor performance and quality standards and so on all over the place. And if you look at the sort of culture test, things like mandatory training, appraisal rates really poor, just weren't happening. So from a turnaround perspective, what we tended to do in that point is to say, well, look, let's sit down and just work out what are the 5 to 10 things that are the biggest issues here that'll either signal that we mean business in terms of turning this around, but equally, from a stakeholder point of view, what are the regulators most concerned about? Let's determine which sort of 5 to 10 things they are, and let's relentlessly pursue those in the same method that we use for our governance and assurance. So we created what we called our improvement plan. And we sort of gave that 3 phases. There was sort of stabilize, which was stop getting worse, start to improve and get in the pack, and then start to excel and get to the, where we wanted to get to over a 3-year period. So in doing that, we were really able to use that same approach of saying, right, these are the 5 or 10 areas. These are the risks that we're trying to address. These are the data sources that are going to tell us whether we're doing it. And then we put in place a program management office across the organization. Now, the key there was getting the responsibility and ownership of those things into the individual hospitals, but making sure that there was a consistent approach to that improvement across the group. So if you look at things like falls or sepsis recognition, early warning scores, mandatory training appraisals, we set the standard and agreed collectively as an organization, this is the standard we're going to make, here's the way we're going to approach it. But then it was down to the sites to deliver it. And within, I think it was less than a year, we'd taken all of those things that were a concern to a very reliable, sustainable improvement that regulators recognised. And very quickly we went from inadequate and unsafe to rated good for safety and good for well-led and all of those things. And we were inspected to death. I mean, we had everybody in on that stuff, and everybody found the same thing. They could see that triangulation of risks, data to tell us whether the risks are improving, and escalation and ownership and clarity about where that happened. So we've taken that approach, and we did it for turnaround reasons, but we've kept it, and we use it routinely now for the way that we do our improvement plan across the group every year. And we've sort of refined it as we've gone, but it's been a very successful way of managing sort of big scale improvement across a complex organization.
So it's a kind of embedding the cycle of effectively, well, plan, but it's almost a plan, do, study, act. It's a, plan, do, review. It's that continually driving a cycle of what's going on here, how do we improve it, how well are we doing type of thing. So
yeah, and that key bit is that focus on a small enough number. It was interesting in the second year, I think it was, that we started to do that. We'd by then got the women's hospital as well, similar issues, ran a similar program, turned around the concerns there quickly. But then as we start to get into that, well, oh, this is great, what a good way of doing this. Let's expand it and do even more things. And inevitably, trying to spin too many plates, it didn't go as well. It didn't happen as effectively. People were more confused about exactly where the priorities sat. So we slimmed it down again the year after. So the key's always been, no more than 5 to 10 things that the organization really wants to focus on. And then at the individual side levels in the organization, their contribution to those 5 or 10 things is made clear, but they'll have things that are very specific to their sites that they want to focus on. So we now have a sort of improvement plan for the group, and we have improvement plans at a site level for those specific hospitals or organizations.
Are any of those priorities kind of things that would be non-easily quantified, or there isn't a kind of data? I'm thinking of some of the cultural and relational issues, or do they always result in something that's a symptom you can measure? So, how does that work?
We always try where we can to get some sort of measurement, obviously, for obvious reasons, but it isn't always possible. And in some cases, we've been prepared as a board to accept input metrics almost as for example, we very early on in the turnaround process, we ran a culture and engagement program with staff. You can do surveys, you can do regular pulse surveys, and we did, and we could see improvement in those. But actually, one of the biggest things was the training and development of a certain type of leadership style that we wanted to embed in the organisation. Very much harder to sort of take the temperature of that. So the board relied more on how many people will we get through this training this year? What's our ambition? Is it 3,000? How will we know if we've done enough of those by the first quarter of the year? What are the outputs telling us? So sometimes it's been more simplistic and focused like that. And some of those things are, particularly in some of the sort of organizational development culture side of things. Yeah.
So I hear a lot about risk, performance improvement, and a kind of a structured way of supporting people with data and making sure that kind of improvement's happening. You talked about leadership development. Have you had to look at and change structures, accountabilities, reporting relationships at all?
When I first got there and we were trying to figure our way through all of this, then yes, we did a bit of that. And we've refined as things have gone on, because there was a point in time we were at 3 statutory bodies and it was potentially going to move to 5, and it didn't in the
Right.
end. But as it was moving to 5, we were thinking, look, there's too many here, and the scale and size of all these different parts of the organisation aren't compatible. So last year we decided, as we knew it wasn't going to move to 5, right, let's take this opportunity now to scale it properly so there's fairly equal scale amongst the 3 component parts of the organisation. So we did that, but there's not been a fundamental change to the method. It's just been more the sort of what sits where within that structure.
Yeah. Well, do you want to say a bit about how clinical leadership kind of shows up in particular in your model and way of working? Because obviously part of the complexity of particularly acute hospitals is the multidisciplinary nature, clinical nature of the work. And then how does the leadership reflect and encompass that?
Yeah, I mean, one of the things that in certainly for organisations of that sort of scale, is particularly when you're in a sort of big group, is how do you make sure the division, if you like, and the triumvirate in the division heard, listened to, involved in decision making, and if all of that across a massive organisation has to come up to a single board through a committee of some sort, it just gets so diluted. So the site-based leadership teams was the key, really, because effectively we've emulated a trust board at the individual sites. Now, the executive managing director chairs that, and they're a member of the group board, a voting member of the group board. So they sit there with their team. What that allows is a fairly small 5 or 6 people team managing maybe a big hospital like, say, Aintree, with, a 600 million budget or whatever it is, thousands of beds, really big place. There'll be 5 or 6 people around that table. So your medical director and your nurse director and the exec managing director. But then the divisions can be part of that as well. And so when they're having a conversation about their hospital, what they've got is the freedom of not needing to have a specific number of non-executive directors and statutory board roles, which allows space then for divisions to be part of that table. And then you get closer, I think, to the patient delivery when they're discussing the stuff that matters. And those hospital management boards are really the place where I would say 95% of the decisions are made. So what you get is those divisional triumvirates with nursing and medical colleagues involved in that. And I think that's a much better way of doing things. And we're not then sort of second guessing those decisions. Those are effectively made by that site. Whereas if you look at the sort of big pyramid structure in a medium to large hospital, largely those things are landing in sub-board committees and board, and you have virtually no divisional representation at clinical level, if any, in there. It's largely just execs and neds. So I think it's a good model. What we then do is we sort of allow the sites to effectively determine how best they want to engage clinicians on there. So we don't have a blueprint for this is how you should do it. It's different to different organisations. The culture's different. The women's is very different to the heart and chest, which is very different to Aintree and the Royal. So we sort of just let them do that. And what we try and do is I meet with those exec managing directors weekly, just if a heads up on any issues, things like that. But we always try and encourage them to sort of share with each other ideas, innovations, ways of working, rather than telling them how to do everything, because it just, you lose that innovation if you do that.
Do you have any cross-group divisions, kind of clinical networks or clinical divisions, or is everything managed within those hospital management boards and the site structures?
So the hospital management boards are accountable for the services that are owned and operated by that hospital, but that could include services that span multiple hospitals. So, for example, Aintree Hospital Management Board, they run orthopedics, and orthopedics sits in 3 different hospitals. So they are accountable for the orthopedics delivery in their hospital. They're accountable for the orthopedic fracture clinics run out of the Royal A&E. They're accountable for the elective surgery that the orthopedic surgeons are doing over at Broad Green. So there's this sort of horizontal group-wide span of control over specific services. But what we don't then do is have I'll explain, there is one exception to that. We do have what we call a senior management board, which meets monthly and is the leadership teams of all the hospitals together. So we do that, and the purpose of that is to discuss corporate risks that apply across the whole organisation. So if there's a big sort of estates facilities risk or a digital risk or whatever it might be, they're all in the room together for that. But we also do a senior leadership forum, which includes then the clinical divisions and the corporate deputies, which is about 200 people once a quarter, which we have to rent a place at Entry Racecourse to get them all in. And that's where we do the sort of group work on things like strategy development, sort of stuff. So yes, there is a sort of leadership and development and engagement platform once a quarter across 200 people across the whole group. There's a monthly senior management board of the leadership teams of the hospitals with the corporate teams looking at the things that are group-wide risks. And then they have their own hospital management boards where they run their sites, basically.
And are the corporate services, the finance, HR, digital, estates, run pan group, or are they site-based still?
That's a contentious issue, that one. We've just gone through the process of tubing everybody to one organisation and having a single set of corporate services.
Okay.
So that's now happened in 1st of April. So as we've had additional organisations come into the group, we decided a single set of corporate services was the right way to go. The slight complexity of that is, at a point in time, there was likely to be a merger of the 3 organisations. We're now going to be in a group model probably for a couple more years, I would think. So we've still got statutorily separate accounts, hence why I've got to sit through 3 audit committees today. So these are the things that are more complex with the group model, because we've deliberately chosen to have site leadership that encompasses. So, for example, in the south of Liverpool, we have only in Liverpool this, 2 separate hospitals, separate foundation trusts that share the same building. So, and then in the north, we've got a hospital and then another foundation trust at the end of the corridor. In the centre, we've got a hospital with 3 corridors attaching it to another foundation trust that we're not responsible for, and then the women's a mile down the road. So Liverpool is a really unique configuration. So the ones we've got accountability for, we've sort of said, look, it makes no sense to have a leadership team on this half of a site and this half of a site. So one leadership team looks after both, but they've got to work through this thing of still for a while now statutorily separate accounts. But other things like policies are being aligned, HR procedures been aligned, all those things are still being resolved.
I think Adam Brooks in Cambridge will have Papworth and Cambridge University Hospitals, the sort of Adam Brooks site. I only know that because part of the work 25 years ago agreeing with that Papworth would move to Adam Brooks, the Heart and Lung Hospital, was that it would remain a separate trust, and it still is. But that sounds relatively simple compared to what you have across the different sites in Liverpool. So yeah. Okay.
Yeah, there's a bit of complexity to it, but we're working through that. So, funnily enough, so in this year's improvement plan, for example, because we know now it's 3 statutory bodies for a while,
Yeah.
one of the pillars of this year's plan is that group development. So rather than, a merger putting everything on one platform, we'll have to work through how we continue to operate with alignment rather than integration, effectively, policies, procedures, etc.
And what are the benefits you think the group model has delivered for the people of Liverpool and the staff of the trust?
I would say, first of all, the sort of structural governance risk model has
Yeah.
definitely delivered huge improvements. I mean, the organisation is light years from where it was for the Royal and for the Women's in terms of the measurable stuff, performance, safety, inspection regimes, well-led, all of those things that have been looked at have come out. It's a significantly safer place and it's a significantly better operating place. If you look at then what the sort of bringing together of the organisations, we're still at the point of working through, I think, some of those benefits. A really good example is the Women's Hospital in Liverpool is isolated. It has, 7,000-8,000 births a year and does not have a critical care and does not have any in reach of anything if anything goes wrong, and would have to transfer by ambulance to the Royal, which is a mile away, but you can wait 20 minutes for an ambulance. So that's just been bonkers since the day I got there and looked at it. That's crazy. So we've just moved this year into, obviously, the Women's and the Royal now having the same leadership team. And what that's done is it's taken a set and a risk register here and said, now these are both of our risks. There's probably, a lot more incentive to looking at how to deal with some of these issues than perhaps there would be when they're separate organisations with separate responsibilities. So you can see already there's already been benefit. But some of the things last year and this year, we've just had a business case approved for significant medical inreach into the women's. We're in the mid-consultation to move a small number of high-risk women to deliver at the Royal, which would then obviously be equipped. So, and also to get maternity support into the 2 A&Es in the city, which have none. So lots of things there that are already starting to pay dividends. We've had some really fantastic stuff with our newer entrant, which is Liverpool Heart and Chest Hospital, a bit like Papworth, as you described, who I think it's fair to say weren't exactly sure why they were joining this group model and specialist trust and, outstanding rating and all of that. And you could understand that. But even so there in the first few months, we've managed to now put in place the first of its kind, I think, in the country, 24/7 aortic vascular rota, because Aintree Hospital has the vascular service and Liverpool Heart and Chest obviously does the aortic surgery. And the clinicians have been trying for years to get a business case or something funded to do this. And when you looked at it, there was always this thing of, well, one organisation's going to have to pay for it. The other organisation's going to have to provide it. We're going to lose money. They're going to get all these crazy things that you just think, why would you do it? So quite quickly, those two just got together and said, this makes sense. Let's just do it and we'll figure it out. And those clinicians now have got that rota in place. So if you're in Liverpool and have an aortic dissection, you are going to be in very good hands because the vascular team are 24/7, whereas previously you might have wanted to make sure you had that problem on a Thursday, which is not realistic, is it? So these are the things that it was all about. I think as we've seen in, some of the particularly the trade press and others over time, lots of vested interest in individuals.
Yeah. And it sounds like that risk model, because it highlights those issues, kind of will naturally raise things up. So yes, but I think you probably need both the construct of the group and the risk model to sort of raise the issues to get those sorts of things tackled and solutions to, as you say, long-standing clinical issue. The number of times I've done a vascular surgery review and you're thinking, oh my goodness, please don't have your emergency on any day other than these days, because otherwise there isn't a rota cover. So yeah.
And that filtering through to the board as well, through that assurance risk committee, is really helpful because you'll have non-executive scrutiny then on problem over here we can't fix, solution over here but not prepared to do it. Why? What's the issue? I'll give you another really good example because it didn't land well, understandably, but the palliative care system in the city provided by a long-standing charity just suddenly decided they were pulling out of provision. And we ended up with a lot of people dying in hospital who didn't want to die in hospital and all of the things that come with that. So the group discussion between the sites was, look, we should step in and fix this problem. We've got enough palliative care team, we can do it. But the only beds we've got available right now, because this was an urgent issue, in the Liverpool Heart and Chest Hospital, and that's not what they do. And probably the best thing to do to an organisation that's just joined a group is not to put a palliative care ward in the middle of your cardiology services. But it was the option at the time. We had that conversation and the sites came together and said, yeah, there's a collective problem for the city. There's a collective problem for patients. We're all in this together. What's the best thing we can come up with? And we've provided that, and it's gone very, very well, and it supports a load of patients. And yes, there was a lot of noise about that, rightly so. People, didn't want their hospital that only did this doing something different on day one. But right thing for patients, right thing for the city, and we'll now work on a more permanent home for that makes sense. But these are things that, I never would have been able to negotiate with another CEO. Whereas when you've got a cohort of people within a single group model who are it's almost looking after their bit of the organisation, but the key bit for me is having those exec managing directors on the board, voting members of the board, means they have a collective responsibility for the group as much as they have an individual responsibility for their site, and it changes the dynamic.
And in terms of kind of workforce development and talent management, I mean, you will now in your group, you're going to have a lot of people and a lot of potentially senior leaders. So your ability to develop them and deploy talent across the group, I guess you've got opportunities you didn't have before. Have you seen that sort of those sorts of things yet begin to bear fruit?
Yeah, so there's an interesting concept in a group model, I think, which is that a lot of people, again, I think it comes back to this thing of if the people who are going to be the hospital chief executive or exec managing director aren't a board member, I think people are reticent to come. I think that's a really important bit of how we do it. So we've attracted really good people to those roles. In the sort of leadership teams that sit beneath that manage the site, that is a really great first role for somebody to step into an executive board position. Now, but the difficulty sometimes with the group model is that they may have sat in a site as, say, a director of operations, director of nursing, medical director in that space, but haven't got a lot of board level experience on a board yet, and maybe aren't ready for the jump into a 2 billion scale massive organization. So I think what we're doing is developing really good people who would get board level jobs in smaller, medium sized organizations. And we've certainly seen that. And people sort of starting to get into that place of applying for those. We've also seen people within our hospitals act up and sit on the board in the absence of others as they've left roles or whatever's. And just operated really well because they've been used to operating in that environment. They know the model. And obviously, and strangely, we've ended up appointing a number of people to our board who were part of our wider collaboration of 5 trusts that was eventually going to come together as a group, but then 2 bits of it didn't. And 3 of our current executive team are from those other organizations who chose to come to us during that period because of the direction of travel, but, have happily stayed and are great members of the team.
So I'm intrigued. What are the issues? You said 95% of decisions are made at site level. What are the things you think do appropriately get made at group level? And what are the sort of things you would say, actually, as chief exec, those are the things I really want to make sure I've got my eyes on? If the vast majority you're saying, actually, I'm trusting local people, we set up in the right framework, we've got the right mechanisms, but these are the things I want to be really involved in.
So there's probably 2 answers to that. One is that there's a sort of corporate set of issues. So, for example, something that's just, a financial plan's always a good one, isn't it? We've got to come to a financial plan for the year. Everyone's going to have to take a hit on that in some way, shape, or form. There'll be winners, there'll be losers, and I might have to broker that conversation across 3 hospital leadership teams to say, look, this is how this looks, whatever. Let's say. So that's an obvious one. The ones that, when I say the 95%, is more the ones that sites can make on their own. Now we have a set of rules, our operating model. And our operating model with the sites was really simple. I'd worked in an organization previously where it was really complicated. And I didn't want some sort of framework that people had to get a book out of a drawer to figure out what they were allowed to decide. So we went with just a very simple 6 rules. Every time I try and recount these, I miss at least 2 out. But the general theme of it is you are allowed to do whatever you like, but in these 6 areas, you have to discuss it first through the senior management board where all the sites are present. So a couple of really good examples that are simple in there is you can't change pay frameworks and conditions without coming to the senior management board and having that conversation. Because if you over there decide to pay theatre nurses a band higher than over here, the next day we've got it here. So it's not a you can't, it's a bring your case and we discuss it together. And if we all agree, then it happens. Another one is changing digital systems. So what we can't have, for example, is one site changing the way that we count admissions or something like that that's going to affect the overall group data. So again, doesn't mean they can't do it, but it just means if it hits that, you bring it to the group. So in our senior management board, every month, the chair of that will basically say, right, we're at that point of the agenda. Has anybody got anything under the 6 rules that they need to raise? And somebody will go, yeah, we've got this pay conditions issue. If I do it, it's going to screw them over there. So we all need to talk about it. Let's figure that out. And the second method is through my exec meeting every week. I meet with the executive managing directors, the person who runs the corporate performance stuff. And we'll sit in there and occasionally someone will say, look, we've got to get to the elective waiting list standard by the end of the year, but this isn't going to happen. I might need to outsource it or pay for it to happen in a different way. It's going to create a problem. Do we all agree? And I'll look to the performance person to say, this is the right thing to do. I'll look for the sites to discuss it and we'll make a decision. So it's those things. And like I say, they're very few, really. They are probably the 1 in 20, definitely.
Yeah. And are there opportunities in the same way that there might be problems or constraints that come up to group level? Are there opportunities where a site has got could do something and in the past there'd be a benefit for them and their immediate patients, but actually at a group level it magnifies the opportunity. Have you had those?
Yeah, absolutely. So that happens in two ways. One, in the sort of group corporate roles. So we brought a commercial director in 18 months ago, who's
Right.
great. And he sort of come in and said, look, there's a whole lot of opportunities here to supplement your NHS pound that would really help in this challenging financial system. I'll work across each of your sites with you. I'll come up with plans with you. So there's a good example of sort of, we've got a subject matter expert who'll work across those hospital management boards and come up with plans for each of them to help them, which is great. In other cases, yeah, we've had people sort of say before, look, I found a really easy way to resolve this problem. Here's how it's worked in ours. And others will say, great, I'm going to do that here. So there's that opportunity to share. What's really good is that those exec managing directors do that between themselves largely. I don't need to make that happen. They do that. They share information regularly. They talk to each other regularly. It's always been the case. And we've got a different group of people as configurations have changed. People have left, people have started, and that sort of still exists. And they speak to each other regularly. So I could probably count on one hand the amount of times over the years that we've come into a room and I've had the 3 or 4 of them, depending on when it was, coming to me and saying we all disagree on something. They've usually dealt with it, come into the room and say, here's our thoughts. Are you happy with it?
Okay, that's helpful. If we can, just 2 final areas to cover. One is, how do you see the role of the NHS providers and a large and important group like the Liverpool group in how the NHS is developing and the 10-year plan? Now, I'm not sure if a change of prime minister is going to change the health policy, but assuming, well, it may or may not, and it probably looks different from Liverpool with the history of Manchester than it might do from where I am down south. But how do you see things developing, and what are the ways in which you think the group's needing to get ready for what's likely to come in terms of how the NHS is developing?
So I suppose for me, being slightly cynical, what I would say is we wrote our strategy or started to draft our strategy out based on population health analytics
Yeah.
18 months, 2 years ago. And unsurprisingly, it came up with exactly the same answer as the 10-year health plan, which we all knew was
Yeah.
logical, wouldn't it? Stop putting loads of people in hospital who don't need to be there.
Yeah.
Stop putting people in huge outpatient queues who don't need to be there. Develop and invest in neighbourhoods. All this stuff been around forever. I was in the original pilots of the PACS and MCP models years back, 10, 15 years ago, where there was money available in those days to test out GP community-led versus sort of provider into different organisation-led approaches to sort of community and neighbourhood development. So what I would say is that that was all very clear, wasn't it? What we've done, a couple of things is, one is we've tried to look at, if we cohort our population into segments based on what they need, but actually more importantly, what they want and how they choose to access it, what does it tell us about that population? And it sort of vaguely groups into 8 or 9 different needs and wants. And they largely arrive in 3 different clinical models that we think that we need to provide. One of those is really efficient and effective acute and specialist hospital care, which is, you need an operation, you need something like, you're going to have to come into a hospital, but it needs to be really well oiled and not split into several different hospitals in the same postcode. And then we had the obvious one of the closer to home neighbourhood care development built around general practice, and how do we play a part in supporting that. But then we had this third part, which was really interesting, huge growth in these segments of our population, which is people who just want a diagnosis and treatment plan, but don't want to wait a year on a waiting list to get it, and don't want to walk into the A&E and wait 2 days to get it. And the answer at the moment is they're their only 2 real choices. Now, there might have been a huge investment in community diagnostic centres, but unless it's going to give an outcome with a plan. So there's a whole cohort. So we took a look at, for example, it's something like, in most organisations, nearly 50% of the outpatient waiting list, when you break it down to what they actually have when they come 40, 50 weeks later, In some cases, here's a conversation, that's it. So you look at it and say, there was no diagnostics, there was no intervention, there was no listing for surgery, there was no bloods taken. It was a conversation. Might have been a very valuable conversation with a specialist and important, but how the hell does that take this amount of time? So we've got into this, what is a completely different model for diagnosis and treatment. We've got to crack that, because if we can come up with something that's completely different for diagnosis and treatment, that gives GPs sort of urgent today answers to things that would avoid a referral or an A&E attendance, there's got to be a lot in that. So we're looking at that. The second thing was, how do we not try and reach from our big ivory tower of the acute provider into neighbourhoods and tell GPs what to do, because we don't know. But how can we make more sense of community services that we all run across our city and make a better offer to GPs around that community response, community provision that's going to help them and neighbourhood teams. So we got together with Older Eye and Merseycare, who are the community provider in Children's Hospital, and we've done some really interesting stuff there around, if you take a sort of a longitudinal look at some of these things, lung health was where we started. We all play it's a bit like this sort of marginal gains thing. We all play a really important part in lung health, but all completely separate. So, there's separate community teams going into homes, there's people coming into the hospital, there's immunisation in childhood, there's immunisation in pregnancy, there's all of these things, and not least the local authorities' interest in the condition of housing. So when you start to sort of break it down to that, what we try to do is to say, well, actually, how the hell do you navigate something like that in our system if you're a GP or a patient? And what is a better way of looking at that collectively so we can provide a single offer between all these different organizations? So we're just working through the legalities of all of that now. But I certainly would see, I've said this for many years, if we can find a way to effectively carve out a significant amount of the acute spend in hospitals and divert it to communities and primary care, then that's the only way we'll crack the problem. Acute provision of things that are going to keep people out of hospital, I've done for many years, and believe me, we suck more people in than keep out. And there's a totally different risk threshold and tolerance of risk with GPs and community nursing than there is with A&E and acute medicine, let's say. So how do you make that shift? It's got to be about carving out. Now, that money's not going to come from anywhere else. So what we've been looking at is, if we bring three organizations together and risk share and try and find a way to effectively create a one-pot system and divert it to places where it's best used, how do we manage the financial risk between the organizations? So there's lots going on in that space at the moment as well. Yeah, probably that's.
Now that sounds exciting, and I mean, obviously the Canterbury District Health Board in New Zealand, Christchurch, who've been at that sort of game or variant of it now for 15 plus years, have shown, I mean, their rate of emergency admissions per head of population is almost half that of the rest of New Zealand. But they've been a long, steady development of relationships and services in that direction. I mean, it clearly, logically feels like the only thing you can do. It's just going to take time to build relationships and shift things, as you say, but that sounds exciting.
Well, the analysis on that, the analytics on the population segmentation tells you one critical thing. You can provide as many services in the way that you believe they would be best accessed, and the patient will find a way to not act in that way, because they just don't know that. They don't understand that level of complexity of the service. They just want an answer. And the trusted brands are the things that are going to happen first. 999, GP, A&E. Unless you change that landscape, it's still, people are going to go to where they've always gone, aren't they?
So final question from me is, clearly there's lots of excitement in the government and in the NHS about the role that AI and generative AI tools and systems can do to help. As what do you think are the kind of practical applications and opportunities that you see as a chief exec, you in your trust, could really make a difference in the next few years?
So I suppose there's a couple of categories here. So if I think about it as a difference administratively is massive, and that might be attractive to patients, but actually I think the ability for it to iron out administrative errors and the problems we have with people-dependent processes is big, and would be a huge impact on the efficiency side of things. If you speak to anyone who's been to a hospital, friends, family, whatever, it's usually a story of, I got there in the end, but I'd had 3 letters that all arrived on different days with different dates, or whatever it is. So the process and efficiency side of things definitely could be much better. And we're running pilots now with Copilot, for example, and our administrative teams are getting to grips with that and finding it really effective. So that's great. The second thing is then in the sort of more clinical space. So there's obviously areas where this lends itself to more than others. So we've been doing this sort of tentative step, but the whole of Cheshire and Merseyside got together and decided to have a look at the dermatology application, and we basically invested in across the whole of the system of that, and the success rate of the AI there was fantastic. It was better than the consultant recognition, which the consultants were very happy to acknowledge and work with. And I think what's great about that is I don't see personally anytime very soon AI replacing the work. What I see is AI taking a significant amount of the easy work away to allow people to concentrate on some of the stuff. So to take dermatology, the consultant's view was, how do you feel about this thing that's doing your work for you and occasionally getting it more often than you? And the answer is great, because all the simple stuff that would have taken me hours and hours to do got triaged out. And now I'm now operating on sarcomas that are really salvageable because I'm doing them in weeks, not months. So it's really helped me get to the bit of my work I need to do. Now, I'm sure there's some sort of analysis out there where someone will say, yes, but repetitive, difficult work is not great for the soul, and people like easy work as well. And how will that impact? To be frank, realistically, I think most people are fed up with the overburden of demand, a lot of which isn't necessarily critical. So I think we'll see an exponential growth of AI taking the burden of the stuff that we probably don't need to be doing. So lots of things like medicines reconciliations, dermatology pathways, early triage, those sorts of things, really applicable, isn't it? So I hope that what we'll see is improved efficiency through the administrative work, and then at best in the next 5 to 10 year window anyway, clinicians being freed up to do what they really need to do, because the AI opportunity is taking away a lot of the stuff that is simple to sort and much more efficient and effective for people to get a straight answer quickly, that's reliable.
Thank you so much for your time, James. Really appreciated it, and great to hear your perspective, and glad you can make your audit committee this afternoon. Thank you.
Thanks, Alastair.